Dan Glazer. I'm the chair of the Institute of Medicine committee that put together the report that you're here for to listen to that. And that report, the mental health and substance use workforce for older adults in whose hands. We're going to go through and describe this report in just a moment, but I want to just make one comment initially. Institute of Medicine reports, as I think that all of you know, are totally independent. However, there are 4 groups that were very instrumental in seeing that this committee was brought together to have our deliberations and to come up with this particular report. And those groups actually are very instrumental in bringing you together here today. Those groups include the American Association of Geriatric Psychiatry, the American Psychological Association, the National Association of Social Workers, and the American Psychiatric Association. So we appreciate them for bringing you together. We have some information that will come both from our perspectives as individual disciplines, which are not specifically part of the IOM report, and we have most of the time will be spent on the report itself. So let me just give you a little overview. In fact, you have in your folders some PowerPoint slides. We don't have PowerPoint, but you can use those slides, and we'll be working from those slides for the most part. We had an excellent committee. I'm not going to sit here and go through all their wonderful recommendations. We actually have 4 members of the committee here today. In addition to myself, there's Maria Aranda, who's over here at the right. She'll be speaking later. Michael Hoagie here, and Christine Bishop, who is in the back, who raised her hand. Christine is an interloper here today. She actually belongs in Boston, but she somehow found her way to Washington, and we're glad that she's here with us also. In addition to that, we had a fantastic support group from the Institute of Medicine. We have 2 representatives of that group here today. Our study director, Jill Eden, she can raise her hand there, and Katie Maslow, who worked with her. This report would not have taken place if that was the outstanding work of Jill and Katie and other IOM staffers. What I would like to say about the committee, however, is quite simply that this was a diverse committee in terms of its racial ethnic makeup as well as its disciplinary makeup. I've chaired many Institute of Medicine committees, and given that diversity and given the topic that we were addressing, which is actually rather broad, it was quite amazing to me how quickly we came to a consensus. So what we're going to be reporting to you today is really something that I think was amazingly understood and recognized as extremely important and necessary to get out in a very specific recommendation to try to push forward what we see to be a very critical deficit. This report really follows on the heels of another Institute of Medicine report in 2008, Maturing for an Aging America, but this report is basically independent of that report, and you need to keep that in mind. So let me go over a few things with you about the report, and then I want to turn it over to Michael and then to Maria. The charge of the committee, it's always important to see this. I'm going to read it. I know you can read it, but at every meeting we read the charge, and so I'm going to read it to you. Determine the mental and behavioral health care needs of older Americans, and then make policy and research recommendations meeting those needs through a competent and well-trained mental health workforce. This was a committee focused on the needs of the aging population in terms of mental health and substance use disorders, and the workforce that would be brought together to meet those needs. In terms of the target population, which older adults are we interested in, we actually cast the net fairly broad. We didn't just concentrate on DSM-4 diagnoses, we spread it higher. We did certainly focus on some DSM-4 diagnoses. These include bipolar disorder, major depressive disorder, schizophrenic disorder, substance use disorder, but we took other behaviors that are critical to working with older persons that need to be identified but don't necessarily fall into our current nomenclature. And they include things like behavioral and psychiatric symptoms associated with dementia and severe self-neglect. And we could make that list longer, but that certainly gives you an idea of the types of things that we included. So we're not just focused on particular disorders. There are some things that were outside the committee's scope, and it's important to keep those in mind. First, we did not look specifically at cognitive impairment in and of itself. We looked at behavioral problems that resulted from cognitive impairment, but not cognitive impairment itself. So this was not a committee focused on workforce issues related to Alzheimer's disease or other dementias. Second, the effectiveness of individual therapeutic interventions was not the emphasis. So we did not specifically evaluate and compare different types of interventions. That was outside the scope of the committee as well. Third, we really focused on substance use disorders, but we did not focus on tobacco use disorders. Clearly a substance and clearly one that is abused and a problem, but that's one we did not focus on. And finally, we did not focus on workforce issues related to caregiver needs. Again, a major issue, but not one that we focused on. It's important to recognize that we can't just talk about workforce for mental health and substance use in general, because older persons are different. And what are some of the things that make them different? Well, the interaction of medical problems, cognitive impairment, functional impairment, and the mental health and substance use problems that they experience is extremely important to recognize. This is something that comes second nature for those of us who work with older persons, but it's not something that naturally translates into the way services and the workforce is put together. So that combination and interaction is extremely important to keep in mind as we go through. We also have to recognize that older persons use frequent medications, and their use of medications will complicate our understanding of the problems that they face. The goals of care often are larger than simply treating an illness. Improving function, keeping older persons independent are equally important. And loss and grief are very frequent among older persons, and that often will overlay other types of issues and must be taken into account along with those issues as well. So what are some of the key findings regarding simply what the need is? I'm not going to go into great detail. We do have considerable detail in the report, but let me just highlight a few things very quickly. First, 1 in 5 older Americans suffer from a significant and important mental health or substance use condition. That's a lot. That statistic comes up over and over again, and 2 million of those have serious mental illnesses. And so these are ones that we cannot ignore. We shouldn't ignore any, but we cannot ignore the serious mental illness, and that makes up 2 million individuals in our country. Depressive disorders and behavioral problems secondary to dementia are the most prevalent, and this should not be a surprise to anybody who works with older persons. Another area is that older veterans, and that's a very important population for us to consider among the elderly, tend to have more problems and more difficulty with these problems. There will be greater members of African Americans, and Hispanic, and Latinos with mental health and substance use problems in the future. There will be more older adults with dementia and associated behavioral and psychological symptoms in the future. The use of illicit drugs is likely to increase, and I will emphasize this just a second, because the non-prescription use of prescription medications is going to be a major problem we will face with older adults. You and I will face with our parents, and my children will face with me perhaps. This is the kind of thing, this is an area that we don't think about, but it's an area that's going to become extremely important in the future. I'm going to stop here and turn it over to Michael, but the needs are significant. We had a great group to come together and try to decide how we deal with those needs. Thank you.
Good afternoon. I'm delighted to see so many of you here today. I'm Michael Hoagie, and I want to talk to you a little bit about the workforce for older adults in this nation who have mental health and substance abuse problems. We look at the potential workforce, which is in fact quite broad. It includes mental health and substance use professionals such as psychiatrists, psychologists, social workers, counselors, nurses. It includes primary care providers, typically physicians, nurses, and physicians' assistants. It includes geriatricians and geriatric specialists, people who have had specialized training within the mental health and substance use professions and primary care to care for older adults. Faculty members are a critical part of the workforce because we need educators who are capable of interesting students in participating in this kind of health care and providing their training. Care managers, who are often nurses or social workers that coordinate care within our healthcare systems and between the disciplines. Direct care workers, who are typically non-degree providers, get on-the-job training, who work in home health agencies, nursing homes, assisted living facilities, and residential care programs. We have family caregivers, one of the largest providers of care that are part of our workforce, and also some peer support programs focused on older adults. We looked at the issue of the training of workers and looked at the context, which is that we know that treatment works and that training the workforce in evidence-based practices of care for older adults with mental health and substance use problems results in better health care outcomes. The models of care which have been best demonstrated around depression and at-risk drinking include things like programs known as IMPACT or PEARLS for depression and PRISM-E for at-risk drinking. They all tend to have the same types of characteristics. They involve systematic outreach to older adults, screening to detect those that have mental health and substance use problems, team-based interdisciplinary care with care coordination, patient and family education and an emphasis on self-management of mental health and substance use problems, provider accountability for outcomes, and follow-up and monitoring to detect and intervene in cases of relapse. Training the workforce in evidence-based practices makes a significant difference in the lives of older adults. There's sometimes a myth that mental health and substance use interventions are not as effective as other forms of health care, but there is clear evidence that they are equal in their effectiveness. So the workforce crisis related to this population is very complex. The number of professionals with training in mental health and substance use problems and geriatrics is very, very small and grossly inadequate to meet the needs of the population. There are about 40 million older adults over 65 in the United States. There are only 7,500 physicians that are trained as geriatricians and have specialty training around mental health and substance use disorders in the entire nation. 1%, only 1% of the nation's advanced practice nurses are certified and work full-time in gerontology. Only 4% of advanced practice nurses are certified in mental health and substance use disorders, and a quarter of them are nearing retirement, having worked over 30 years in the field. In my field of psychology, in 2010, there were resources available to provide advanced postdoctoral training in geropsychology to only 22 students. We also found that in some professions, the number of people doing this work is actually declining. We have funded training slots that remain unfilled. Sometimes up to half of the funded slots remain empty. And we have specialists who have had the training who are actually letting their certification in this work lapse, largely due to the disincentives in our payment systems for providing care to older adults with these problems. Other professions don't have any funding to provide dedicated training in geriatrics or in geriatric mental health and substance use disorders. We don't have enough faculty to actually train the workforce. And the vast majority of providers who are actually providing services to individuals over 65 have never had any specialized training in meeting the mental health and substance use needs of those individuals. So there are a broad range of workforce development needs. We need preparation around geriatrics for the mental health and substance use specialists. We need training in mental health and substance use disorders for those that have had training in caring for older adults. And for the primary care providers, we need both training in geriatrics and in mental health and substance use disorders because they typically do not obtain that training either. We need to build faculty recruitment and development initiatives. We need training for the direct care workers, the family caregivers, and peer support providers. We need to focus on reducing the stigma related to working on with this population because we're battling the stigma related to working with mental illness, with substance use disorders, and older Americans. We need incentives that attract and retain providers for this work, and we need focused recruitment of individuals from diverse backgrounds to this workforce so that we ensure a culturally relevant and competent workforce for this population. So in terms of some broad conclusions, a substantial proportion of older adults have symptoms that warrant the attention of a provider skilled in geriatric mental health and substance use problems. 20% of older Americans over 65 meet that criteria. Yet only a very small minority of affected individuals will receive specialty care for these problems, and those that get their care from primary care are likely to get treatments that are inadequate and ineffective. The inadequate care leads to poor healthcare outcomes and increased healthcare costs. While these demographic trends and the evidence of the prevalence of mental health and substance use problems in older Americans suggests a dire and urgent need to prepare the workforce to care for its senior citizens, our parents, our grandparents, there is a stunning lack of attention to this growing crisis at the federal level, at the state level, and throughout the healthcare system. Now I'm going to turn it over to Maria Aranda to talk to you about some of the recommendations.
Good afternoon to everyone. As a social worker and a family caregiver to persons in my family that suffer from both mental health and substance use disorders, it is truly an honor to be here. Given the state of affairs that my two colleagues have eloquently presented today, our committee developed a set of 5 recommendations that cross diverse disciplines in the service of enhancing an available and competent workforce for the 21st century. The barriers that we talked about today must be overcome, but really across designation, authority, planned action, etc. And our recommendations follow suit. I'm going to talk a little bit about the 5 recommendations. Because of the interest of time, I'm going to make sure just to list out the recommendations and just give a few subpoints. You can refer to the more fleshed out recommendations in the report itself. So our first recommendation addresses the importance of locating a locus of responsibility and authority for a sustained and coordinated workforce. So the first one is Congress should direct the Secretary of Health and Human Services to designate a responsible entity for coordinating federal efforts to develop and strengthen the nation's geriatric workforce. Congress should fund the already authorized National Healthcare Workforce Commission to serve in this capacity. In the absence of such congressional action, the Secretary could designate an alternative entity or body. But this body should have at least these following priorities. Number 1 is the development for the methods for improving not only recruitment, but retention for this personnel, and also for the curricula that follows. Not only to work with older adult populations, but also for their family caregivers. Also, a promotion of wide-scale implementation of evidence-based models of geriatric care, not only to deploy the personnel, but also to develop quality curricula that follows. And last but not least, to help in the development of core competencies across disciplines, or for core competencies that are already developed to advance them for practice in the 21st century. Now, our second recommendation addresses the role of the agencies under Health and Human Services, not only to sustain the work that has been attained to at this level, but to accelerate future advances in the development of a quality mental health and substance use workforce. For example, the Secretary of HHS should ensure that its agencies, and that could include AOA, AHRQ, CMS, HRSA, NIDA, NIMH, and SAMHSA, that they assume responsibility for building this capacity and also facilitating the deployment of this particular workforce for older Americans. And I've opted only to give a few examples for some of the agencies due to the interest of time. For example, CMS should really evaluate methods for reimbursing care managers that we've delineated, for example, in the models of care. and other mental health specialists that are also serve as supervisors or managers. Also, CMS should evaluate methods for deploying personnel in community mental health centers to provide older adults with quality primary care services, but also chronic disease self-management as well. We could also explore ways to enforce already existing rules for mental health and substance use assessment in skilled nursing facilities. For example, I'm referring to the PASSAR and NDS rules. On the other hand, HRSA, the HRSA administrator could ensure that the National Center for Healthcare Workforce Analysis devotes sufficient attention to the geriatric mental health and service use planning. Also, the Geriatric Academic Career Awards development grants should include awards for specialists that are currently working or intend to work with older adults and their caregivers who have mental health and substance use conditions across care settings. The director of the National Institute of Mental Health should ensure that research is conducted for the methods that are needed to increase the capacity of the mental health workforce for older adults in the community, nursing homes, or other congregate residential settings. So we need, for example, the research that undergirds that particular focus. Now, SAMHSA administrator could ensure that they restore the already terminated grant program called the Older Adult Mental Health Targeted Capacity Expansion. We did find that there were several excellent exemplary programs that have since been terminated in the last few years. Also, the states that receive block grants, mental health service use block grants, they document and report how the funding is being used to support a local capacity for older adults and their caregivers. Now, recommendation number 3 acknowledges the need for core competencies in this area and also specialized training that cuts across disciplines, settings, and models of care. So the committee has recommended that organizations that accredit, certify, and also state licensing boards, that they need to modify their standards, curriculum requirements, and also procedures for credentialing for not only their existing workforce, but also for those that are out in the field, for example, when they come up for recredentialing. Now, recommendation number 4 speaks to the dearth of support or incentives for recruitment, training, and retention of the diverse workforce. So funding should be appropriated for training, scholarships, loan forgiveness provisions of the Affordable Care Act for those who are working or intend to work with this population. And this includes a wide spectrum of practitioners and specialists, not only specialists in this area, but healthcare providers, care managers, faculty from diverse fields and disciplines, direct care workers across many settings, and of course family caregivers. And last but not least, our 5th recommendation is to have the HHS should direct the coordinating entity to develop and coordinate data collection and the reporting of this data out for our country. Data collection could involve things like prevalence data that cuts across age cohorts, ethnic and racial backgrounds, language capabilities, and also areas of living arrangements and care settings. We also need data on the scope and breadth of mental health and substance use services. And lastly, we need to be able to characterize and profile what we mean by the mental health service use workforce. And that could include indices in terms of what do they look like, who are they, what type of work Where do they complete? What are their geographical profiles, their qualification, language skills, the type of training and certification that they needs, the areas of practice, and also the hours spent in the care of older adults. With that, that completes my section, and we will be holding a question and answer period after. Thank you very much. It's been a pleasure.
At this point, we're going to switch our orientation from itself to something to get not here. I'm going to stand there. At this point, we're going to switch from the report itself to just a very brief description of how this report might influence and impact 3 specialties. Now, what I would suggest to you is that the groups that we're going to be talking about are representative of a much wider workforce that's working with older people. So we're going to give you the reflection from 3 different ones. Geriatric psychiatry, I will do that, and then Dr. Hoagie will be talking about psychology, and Dr. Aranda will be talking about social work. Geriatric psychiatry is a relatively new discipline. It is about 35 years old, as best I can tell, and I've lived through most of this time. From a time that it was basically an interest and an advocacy among a very few psychiatrists who had an interest in older persons, it's become an established discipline with an identity and with a considerable expertise. And so it's very much a growing organization. I listed in the first slide a number of examples of how this particular group has grown as much as it has. Geriatric psychiatry has added already, we can determine, real value to the care of older persons with mental health and substance use problems. It's first off been critical in establishing a research base that provides us the information we need to develop the practices that will help older persons. It is also mastered and even interesting for the diagnosis and treatment of mental health and substance use conditions. In other words, we now sort of have a knowledge base that enables us to work in a much more sophisticated and efficient way in diagnosing and treating older persons than we've had in the past. It's critical for teaching, and I can't emphasize this enough. Most medical schools in the country now have a division of geriatric psychiatry within their departments of psychiatry. This serves as a nidus to keep geriatric mental health and substance use problems on the radar screen of psychiatry programs and medical schools in general. That was totally absent a few decades ago. It's now there. It's now very clear. And geriatric psychiatrists by nature are team players. We've talked about throughout this report the importance of us being a team. Geriatric psychiatrists, maybe unlike some other physicians, really have learned to be team players. But there are some challenges. Medical school and residency debt often preclude the additional year of training in geriatric psychiatry, and this would be true in many other areas where individuals might go into fellowship training. The debt keeps them from training and pushes them out into practice as soon as they complete their residency. There are virtually no financial incentives once they complete their fellowship to pursue a subspecialty career, not only specialty training in geriatric psychiatry. There are many other incentives, though, and this is sort of what I consider the real opportunity. Many of my colleagues will say, geriatric psychiatry really is fun, and if I had the financial ability to practice there, this is exactly what I would be doing. So we have a mature discipline that is poised to work with older persons that is struggling at the present time primarily because the financial support is not there, and the institutional support frequently is not there as well. Thank you.
So I want to just make a few comments about the discipline of psychology. There are over 90,000 clinically trained psychologists in the United States. It's one of the largest behavioral health professions. Psychologists are health professionals that are trained at a doctoral level, and the median amount of training after undergraduate degrees is 7 years. We have about 25,000 to 26,000 students in graduate training at any point in time, so it's a very substantial pipeline of mental health and substance use professionals. About 40% of psychologists spend some time serving older adults, and there are multiple specialties within psychology that have relevance to the care of this population. Geropsychology is that which is most specific about training related to mental health and substance abuse care for older adults. There are 4 paths to geropsychology specialization that involve graduate school, internship programs, postgraduate fellowships, and continuing education. There are other specialties such as neuropsychology that contribute, as do a variety of behavioral and cognitive psychology specialties as well. Psychologists provide a broad range of services that are relevant to the care of older adults. This includes the assessment of cognitive abilities and differential diagnosis of psychological and neurological disorders, something that's really key in this population. They provide a broad range of psychological interventions from traditional psychological therapies, behavioral interventions such as pain management, focus on sleep disorders, incontinence. They participate in collaborative and integrated care programs, such as the innovative programs that I mentioned previously, and they provide a variety of preventative services and services related to the management of chronic disease. The focus on weight reduction and weight control would be just one such example. They've been involved in the design and intervention of integrated healthcare models, and with their background in research, they provide a great deal of research and evaluation of healthcare interventions and outcomes, including in the area of older adults. And they receive generally training regarding management and supervision and consultation, which has fostered their role in comprehensive systems of care. There are a variety of challenges and opportunities for psychology. The first is related to securing adequate funding for education and training in geriatrics. And we have every year 6 applicants for every 1 position that we're able to fill in the specialized slots for geropsychology training. This past year we had 1,000 graduate students who were unable to secure a required internship in clinical or counseling psychology. Many of those individuals could be easily sort of enticed into working in the area of older adult mental health and substance abuse care should we be able to fund those internship slots. The Graduate Psychology Education Program is the only federal funding that exists that's dedicated particularly to psychology. In 2003, there were funding was set aside for geropsychology programs, and 7 were built over the ensuing years, and then all eliminated. The program was defunded in 2006. We think this is one of the classic examples where we're headed very much in the wrong direction given the train that's coming at us in terms of the level of need for this population. We do see one more thing related to the health professions programs. We've seen some gains through the Affordable Care Act in terms of increasing psychology inclusion for some of the geriatric types of faculty development funding. As you know, some of those provisions in the Affordable Care Act have not actually been funded. In other areas, psychology is just beginning to participate in the Geriatric Academic Career Awards, for example. We have 1 psychologist that's funded this year in a faculty development program. So it's a start, but we have a long way to go. We see very good trends related to some of the legislation, such as the Affordable Care Act and the Positive Aging Act, which is currently in committee. Because of its focus on inclusion of multiple disciplines. The Positive Aging Act focuses on mental health and primary integration demonstrations and the funding of outreach teams to reach older adults with these problems. Lastly, we need to see increased access to mental health care and substance use care by enacting Medicare and Medicaid policy reform. The IOM in its press release about this report stated, and I quote, "Medicare and Medicaid payment policies deter effective and efficient care for substance abuse and mental health conditions by limiting which personnel can be reimbursed and which types of services are covered." Psychology has been a large and available workforce for older adults, but under Medicare, the provider definitions needlessly restrict independent practice of psychologists, creating barriers to access and disincentives actually participating in caring for this population. Psychologists are excluded from some Medicare-funded programs such as transitional care management, and the decrease in reimbursement rates for psychological services overall has dissuaded many psychologists from pursuing this work. By conclusion, I would simply say that I think psychology can make an even greater contribution to the care of older adults if there's enhanced funding for training, inclusion in federally sponsored initiatives, and payment reform that encourage people to pursue this specialty. Thank you.
Thank you for being so attentive. The field of social work would not be considered a young field or a young discipline. Here in the United States, the field of social work is over 100 years old, and we began with a history of the friendly visitors, later the settlement house movement, and always have allied ourselves with groups that are considered marginalized and disenfranchised. And we continue that legacy and that history to this day, and I say that with a lot of honor and respect. Right now in the U.S., there's an estimated 642,000 social workers. About a third, a little over a third of their social workers in the U.S. identify mental health as their primary practice area. But if we look at social workers in total as a group, we represent the largest mental health and service use workforce group in the United States. Social work spans different levels of experience, education, and settings. We have the Associates of Arts degree, BSW, MSW, also doctoral degrees as well. But in order to practice clinical social work and many of the models of care that were delineated today, you have to have an MSW for advanced clinical work and also for some supervisorial and managerial positions. Clearly, if psychotherapy is going to be provided, or assessment and diagnosis, the individual does need a clinical license or be under the supervision of somebody with a clinical license, and the person would be able to either work on a treatment team or also provide psychotherapy in private practice. Now, what is it that we do? We've come a long way, baby, as they say. Still entrenched in our roots, working with marginalized populations, issues of diversity and empowerment do reign. But we also include very direct practice. For example, many people have certain stereotypes and stigmas regarding what a social work does, but we do many, many things. And I use this opportunity to be able to share with you some of the roles that we complete. For example, we can provide evidence-based psychotherapy, manualized therapy. We do provide family interventions, therapy to individuals, families, and groups, resource development, public policy, social action, etc. So these are the particular job responsibilities that social work is well positioned in order to be able to execute. Now, one of the things that I'd like to leave with you are some of the recommendations about what we need to really look for in terms of social work. Well, first of all, we need to support the development and testing of workforce development strategies that really ensure this glue, so to speak, this point or union of aging material or content and substance uses and mental health conditions. We also need to guarantee that we are considered as social workers part of the treatment team for these models of care that are delineated in the IOM report. Getting more into some of the details, We really should look at unbundling some of the clinical social work services from those services that are provided in skilled nursing facilities and long-term care facilities, especially those that appear in the Part A payment, because we need to have alternative payment methods that are not bundled into one fee structure. Also, we should require that BSWs and MSWs in the skilled nursing facility workforce increase the identification and referral of individual residents in their facilities that need follow-up care or assessments in terms of mental health and substance use issues. And lastly, we need to support the ACA workforce provisions and associated funding for training, scholarships, and loan forgiveness. As faculty at the University of Southern California, I do find that where the money goes, the bodies go as well. So we want to make sure that we provide the funding that's needed for students to get into the pipeline early on in the process. Thank you.
We want to open it up for discussion now. My voice is a little weak, so I'm going to stand up here. I'm hoping that Michael and Maria can speak from where they are. When any of you can speak, make comments, ask questions, this is your time. So I'll open it up. I cannot believe nobody talks on Capitol Hill. Yes.
My name is Rebecca May Cole. I'm with the Pennsylvania Behavioral Health and Aging Coalition. I just want to thank you for this report. I think it's very needed. My question, and I'm glad to see that you had peer support listed in here. Was there any more discussion about the possibility of model programs using peers or reimbursement from like Medicare? Pennsylvania actually has Medicaid reimbursement for peer support services, but I didn't know if there's any talk of Medicare doing something similar.
We certainly looked at some existing models of care and made the recommendation that Medicare needs to be adaptive enough that it can support those existing care. We did not get into new or planned models of care. We did not try to invent something that was not there. I think the general overall thrust of the report, however, is that we have to be more flexible across the workforce in terms of funding to permit these models of care to work as effectively as possible. And direct care workforce was a very clear focus of what we did, so that was extremely important to us.
Dan, if I could just add to that, one of the things that was very much of concern to us is we saw very little happening nationally related to training peers to work with older adults with mental health and substance use problems. So while this is very much an emerging area and quite strong in some areas, there's very little that's happening. We saw the recommendation around developing competencies as something that would be relevant across all the work groups, including the peer level, to help strengthen that side.
Pennsylvania is actually doing some work in training peers and working with older adults, so if there is any interest in following up, we would love to talk about further.
Thank you.
So I'd like to just add something, if I may. Also in California, with funding from the Mental Health Services Act, funds peer support programs, recovery programs are being funded from that particular funding stream, not only in large counties, but in small counties as well. And I'm sure the State Department of Mental Health can give information on that.
Other comments, questions? Yes.
Hi, I'm Bob Conley. I'm retired from CMS, and I've been working with other professionals to look at nursing home manpower and how to really support them. One of the staggering statistics is that only 5% of master's trained RNs and 5% of master's trained social work choose geriatrics. I think the nurse practitioners are now going to perhaps no longer have a geriatric specialty because they couldn't get as many people and they feel they can train geriatric. How did your committee look at how do we get the interest and fight the societal biases that get young students to choose geriatrics and to get to them earlier than when we get to a master's or doctoral level?
It's a multi-layered question with multi-answers, but I think at least two things we focused on. One is going against the trend that you're describing. I think individuals who have more training are more likely to stay in the field and really see this field as a passion and will stick through some tough times in it. Another issue clearly has been the financial strain. The additional training cost, and that additional training cost ends up costing them down the road, and so they actually end up less well off than individuals who've not gone there. So those are two areas that we've looked at. I think that we did not directly address the issue of bias in terms of how that might affect the workforce. We certainly recognize the importance of bias in terms of how policies are put together that tend to neglect mental health problems in older adults in terms of substance abuse and mental health problems. Jill, do you want to say anything about this? You're looking like you might.
Not really.
If I can weigh in here, the one thing that was very clear is that decisions are made relatively early about specialization, and if you look across the disciplines, very few people receive any early exposure to working with older adults who have mental health and substance abuse problems, and there are very few mentors since there are very few faculty skilled in this. So early intervention, early exposure to the work, and mentors who can model the work seem to be absolutely crucial.
Yes.
I'm Carol Pratt from Senator Rockefeller's office. The Institute of Medicine is a wonderful organization, and they recently put out 2 interesting reports on oral health in the United States. In one of those books, the president of the IOM had mentioned that everything from the neck up seemed somehow to be disconnected from general health. That is mental health and dental health. So I'm asking you how you considered dental health when you looked at this issue, and how you talked about incorporating dental practitioners in the care of these very special patients.
Your point is very well taken, and unfortunately we did not consider dental health, but I think that's I think that's a very good point. And I think I would say I think there certainly is everything from the head up tends to be cut off from the rest of the body, but I think the mouth and the brain tend to be cut off perhaps even more. And for that reason, I think that probably is an area that's neglected. I think that obviously many older persons will receive care in a dental office, and issues can be picked up there and maybe have to be dealt with in a dental office that they could not be able. And there also is emerging evidence that there's direct connections between a number of physical and mental health problems related to dental things. But we did not address that in the report. It's a very, very good point. I appreciate you saying that. Yes?
Joan Baird, American Society of Consultant Pharmacists. I kind of like to dovetail on what she just said. Another profession that probably should be at this table would be our consultant pharmacists, our geriatric specialists, in other words, who by regulation review charts in all the nursing facilities every month, and who have a unique and very important perspective on the problems that you've all alluded to, such as polypharmacy, substance abuse in seniors, abuse of prescription medications in seniors, and so on. So I kind of like to see that profession at the table as well. I think we could bring quite a bit to your booklet. And I didn't see any in a quick perusal on your committee.
That again is an excellent point. I think both in dentistry and in pharmacy, there are clearly sort of, they may not be subspecialties, but there certainly are emphases that look at geriatrics, and so these areas actually have begun to step out of the
Yes, and our society does specialize in geriatrics, and there is a separate board certification.
Dan, if I could add something to that. I think this went well. Okay. To dovetail on the 2 comments that were made, right now we are at the School of Social Work at USC. We're developing a program in conjunction with pharmacy, primary medicine, OT, PT, etc., even the dental school. Actually exposing our interns from these respective schools to doing ground rounds or working with community people in their homes and exposing students to the interprofessional issues that come out in multidisciplinary assessments, and it's going very, very well.
Yes.
Actually, excuse me, Ellen Garrison with the American Psychological Association, and a related question. I'd be interested in hearing from the panel about the role and value of interdisciplinary training and practice, and also about the growing need for culturally competent care, given the diversity of our aging population.
So Maria can certainly speak to the area of cultural competency, but this is certainly something that was front and center, I think, in most of our discussions. We feel like this is extremely important, and given the changing demographics of our aging population, this will obviously become increasingly important as time goes on. So I think she should make a comment about that, because she really was the person who probably was our major standard bearer in that area. In terms of, I forgot the first part of it. In the interdisciplinary, you know, we certainly talked about that, but quite honestly, this is so inherent in what people in the different specialties that made up our committee we just kind of assumed that takes place. So we did not specifically focus on that, except the recognition that we must be working as a team. But most of us, in fact, do work as a team. But I think your point is well taken in that what our assumptions might be and what's kind of inherent in our own practices may not translate out to a larger society, and we really need to push that forward. I'm going to let Maria speak just on the cultural competency just a second, then we'll come back to you again.
Sure. As a committee, we were struck with the issue that this group of older Americans is becoming increasingly diverse. Diverse in terms of not just geographic living arrangements, but also in terms of culture, ethnicity, linguistic and language differences, etc. I could go down the line. But also the workforce is increasingly diverse. So you have almost this occupational parallel process that's really following this increased diversity with the older Americans and their caregivers. What is needed are methods to really identify methods for testing what is a culturally competent curricula or culturally competent methods or models of care. Many of the models of care that have been highlighted not only in the IOM report but in other documents really lack the diversity that is needed to be able to make more stable statements regarding effectiveness, workforce development issues, etc. So I'm hoping that with the recommendations we can develop those methods, not just looking at what cultural competency is, but how do you know when you see it, how do you measure it, and how does it affect outcomes for this population?
Thank you. We got a question back here.
Hi, I'm Linda Kaplan from SAMHSA, and I just wanted to sort of highlight a few things that people have said already. And one is, I think the diversity of the workforce is going to be key, but we're really hitting a tsunami here of a rather not large enough and unprepared workforce for a population that is increasing by leaps and bounds. And one of the things that does concern me is really the interdisciplinary, and by this I really mean the interdisciplinary need to work as part of a team with both primary care and mental health and substance use disorder practitioners, but also with peers, with home health aides, with community health workers. People are going to be in their homes more than they're going to be in nursing homes. It's a wide range of providers. The other thing that I realize, and I realize that there are not going to be enough slots, certainly in the foreseeable or near future, to provide internships and fellowships for enough of the professionals that we need. But the ongoing in-service training really needs to include a focus on geriatrics, a focus on prescription drug misuse, which is already a crisis, but is going to become more so, and a number of things related to that. So I would urge you to look at both the current workforce as well as the, sort of pre-professional, pre-service training and education.
I will mention one area where the interdisciplinary work really was a focus of the report, and that is in the section on models of care. That's very much what we see as be sort of the phase of the future, and that assumes groups of individuals working together under a model that's been proved to be effective.
Yeah, if I could just add to that, those models are all interdisciplinary in nature. There are also tests of those models with culturally diverse populations that are starting to occur, looking at the adaptations that are necessary. Some of, in terms of being multidisciplinary, there are many other professions that are not represented here today that we looked at in the report, I think including pharmacy, They all play sort of very substantial roles in this workforce. But if you look at the data we've provided, many of them are actually losing ground rather than gaining ground. Professions are closing training programs related to the care of this population, even though the need is going to be so much dramatically greater. Some of the professions are working on competency development for integrated care. We have a long way to go within our training programs to sort of increase that emphasis, because that interdisciplinary experience tends to be learned mostly on the job at this point.
George?
I'm George Nedry from the National Institute of Mental Health. In your presentations, you mentioned the importance of developing core competencies or defining core competencies. And I wonder if you could say a bit more about how you see that process unfolding. Is it something that you're recommending occur within each sub-discipline, or is there some more generalized kind of core competency here that we're talking about? And if so, who would you think is responsible for seeing that go forward?
I think the answer to that is both. Michael actually is working quite a bit on this, and I'd like to ask him to speak on this as well. I think the answer is both. We stopped short of coming up with a list of core competencies, but we talked about core competencies a lot. That is a list for the report. We believe that there are certainly core competencies that cut across all disciplines, but then there are going to be discipline-specific core competencies. And we certainly make recommendations, as you see, that say we need to develop these core competencies. And again, in a different light of what Maria was saying, we need to hold disciplines' feet to the fire in terms of making certain that these individual areas are trained and they're tested.
I think the vision that we articulated in the report is that while we understand that the various professions are working on competencies, that there is a need for them to work together to create a common set of competencies. The history of competency development, which isn't that old in healthcare, is that of many different disparate groups building sets that never really see the light of day or have substantial impact. And this is an area in which, by working together, there could be a set that would inform all groups and use our sort of precious resources to accomplish that goal, and translate to other groups that will never have the resources to build competencies, such as the direct care workforce, for example, into the peer support areas that we talked about. The structure that we propose, again, is that there should be some central coordinating authority at the federal level to ensure the flow of resources and either create the coordination or stimulate the coordination that would bring groups together to develop and promote those competencies through then curriculum development, etc.
Next. Yes, Mike.
I have probably 1,001 comments, but a couple things that just jumped out at me, especially the woman from SAMHSA, the discussion of, and actually this gentleman also, the discussion of the aid level. I mean, that those are the people that see the older adults in a lot of cases on a day-to-day basis, and having that in-service training or some level of competency there. While they're not the people who are doing the the advanced practice, people getting the advanced level degrees. I think it is still important for them to understand how to work, especially with the behavioral modification and issues. You can de-escalate situations so they don't end up getting to the point of needing to go into emergency rooms or getting that higher levels of care. And also, especially in the nursing homes, the unbundling comment that wasn't exactly, I think, talking to this, but the unbundling of nursing homes so that additional funding could be used to pull in the experts that they need to. A lot of nursing homes we hear in Pennsylvania say we can't afford to pull in, even though the rates are supposed to cover everything that the person is supposed to need. They are not able to pull in the disciplines that they need to because they've got so many other expenses. So I think that was something that I just wanted to comment on as well.
What else? Yes.
Yes, I had two questions. First for Dr. Hogue. You mentioned the impact study and as a model care delivery model for integrated care, behavioral health and primary care. And then there's also the Diamond model, Diamond Project Minnesota, and the MHIP in the Pacific Northwest. Are you following up to make sure that, in the integrated care reform community, that they always talk about geriatric as a feature of integrated care, because there's so much going on in this area right now. You know, it's certainly an area in great flux. And then the second question for the panel as a whole, I noticed that the recommendations are geared primarily at federal government agencies. Do you have plans to follow up to reach the broader society? A lot of these are cultural issues, like for instance, working with AARP to get across to the culture, you know, the issues that are looming for baby boomer, to, you know, get some of these concepts into the public discourse so that some of the baby boomer cohort can be thinking about, you know, areas of aging well and self-care and so forth. And also reaching out to millennials in terms of the workforce issue, because as head of a nonprofit, we find that a lot of these social issues, you know, young people under 30 are very interested in, and then you dovetail that with the fact that this is a great career job growth area, the whole healthcare field. So just those questions on the integrated care and getting these messages out to the broader culture.
Let me answer the second one first, and then I'll come back to Michael to answer the first question. In terms of getting the message out, the report was commissioned by Congress, so we report back to Congress, and that's why the recommendations are basically shaped as they are. One great goal that we have, and actually I think in part it's certainly been realized here, it's been realized by some of the news report, the publicity that this particular report has received, is that the report will get traction in terms of the public as a whole. And it's more important not just that the report get traction, but that the concepts that are inherent in the report get traction as well. This is one step toward doing that. So that's why the report is written as it is, toward making recommendations to the federal government, because that was the target of what we were asked to do. But we certainly hope this report can become a building block in terms of getting more knowledge out. Just the things that you're describing, I think, is extremely important.
I think the answer to the first question is somewhat similar, that the Institute of Medicine's job is to pull together in an unbiased fashion the evidence and to suggest recommendations, but does not carry out those recommendations. With respect to looking at the various models of care, we looked at them for their implications around workforce development, what their inherent nature of the workforce tasks were, the direction of the workforce, and our responsibility was to highlight those and again to then, through some dissemination efforts, sort of make them public, but it really is the state, federal, professional association, advocacy group level where those ideas would be taken and sort of move forward.
These reports tend to have a life. Sometimes they have a short life, but hopefully this is going to have a long life. And it's a report that people will refer back to, use as evidence to try to build just the types of efforts that you're describing. So we think this report, given the initial reception of it, is going to have a long-lasting effect in terms of shaping things in a very difficult environment.
May I add something, Dan? In terms of your comment regarding integrated care, in Los Angeles, right now I'm part of a county-wide effort training personnel across different disciplines on the effective launching of problem-solving therapy or problem-solving treatment for behavioral health workers. And although they will cite IMPACT or MHIP, they forget the fact that these studies were developed for older adults. So I remind them quite a few times. Second, in terms of your broader message question, I think everybody here has really the responsibility to do not something just with this report, but being able to really form the lexicon and the discussion that's going to occur in the next few years regarding baby boomers. Right now, I've agreed to be part of a advisory panel for AARP on caregiving. In the first week, we had 200 calls on this line that they've established just on caregiving. Many of the questions revolve workforce questions. Who do I hire? Who do I look for? What type of specialist do I need to care for my partner or my older parent?
What else? Yes.
In terms of your recommendations about more support of loan forgiveness, specialty training, usually that comes from Congress to the federal agency, or are you envisioning that federal agencies have money to put into this? Because I wonder if there's any legislative kind of support to follow up on this and how it'll play in all that.
I do not understand Congress, but my sense is that this is iterative, and that basically I think the message to Congress is these are areas that have been cut and need to be reinstated. The message to the agency is, you know, if you're diverting money to other areas, you're making bad mistakes, because this is going to be the tsunami that you talked about that we really have to attend to. So I think it's a back and forth between the two, so in some ways we're targeting.